Hello, dear friends. Myself, Dr. Devesh Mishra, and I am going to discuss today a very important topic, which is quite helpful in the clinics also. And this was the question in previous year INECT exam also. So it will be helpful for both, right? That is the thromboelastography. So let's start. What is thromboelastography? Thromboelastography is a method of testing efficiency of the blood coagulation, right? So see, blood coagulation, we know that we use PT, APTT for measurement, but remember there is a term called efficiency. What is efficiency? Efficiency means interaction of the platelet to the clot factor, which we cannot see by PT and APTT. So that is why we are using a dynamic procedure which is called as thromboelastography. So where we are going to use thromboelastography, why I said it is useful for the clinicians, which kind of clinicians? Surgery, anesthesia, emergency department, intensive care units, and labor and delivery departments. So all these areas you can follow up the process of coagulation by using thromboelastography. And there is a called thromboelastogram. The graphical image which we are going to measure this efficiency of the blood coagulation is called as thromboelastogram, right? So what is thromboelastography? As I said, this was the question also in previous year INICT exam. It's a hemostatic assay to study efficiency of the blood coagulation, right? So how we are going to study efficiency? As I said in the previous also slide also, efficiency of blood coagulation means each phase of the clotting process. Each phase of the clotting process where you are going to see platelet involvement, fibrin accumulation, then fibrinogen to fibrin conversion, then fibrin lysis. So all these steps we can analyze. That is why I said efficiency of the blood coagulation. In simple PT, APTT, we are not measuring how fibrinolysis is going on, how fibrin accumulation is going on, how fibrinogen is getting converted into fibrin. All these things are not measured. So dynamicity of the coagulation pathway is measured by thromboelastography, right? So what we are going to do here, we are going to measure the interaction, right? Why it is dynamic? Because it is going to interact between the, it is going to measure the interaction between the platelets and the coagulation cascade, right? So in TEG, basically we are assessing the components of the thrombus formation, right? So why I said it is a dynamicity of the coagulation pathway, because it is going to measure the components of the thrombus formation, and thrombus formation requires four important components, right? So they require four important components. So what are these four important components in any thrombus formation? Number one is the platelet aggregation. Number two is the clot strengthening. Number three is the fibrin cross-linking, and number four is the fibrinolysis. So we all know about all these things, right? These are the basic things. Platelet aggregation, what they are going to do? See, platelet will form the hemostatic plug. You remember, whenever there is a minor cut, first what will happen? Platelet will come and they will attach with another platelet. So this platelet aggregation is called as hemostatic plug, primary hemostatic plug formation. So this is number one, platelet aggregation. Then there will be the next step, that is the clot strengthening. So what will happen? See, platelet itself or platelet alone cannot give a strength to the clot. So they require clot factors involvement. So now clot factors will come and they will reinforce the platelet. So now I understand, this is the beauty of thromboelastography, dynamicity of the coagulation pathway. You can see here clot factor, now they are coming and they are involving, that can be also measured by them. So fibrin cross-linking, third step is the fibrin cross-linking. Fibrin cross-linking means now fibrin is coming because of the fibrinogen is converted into fibrin. Now you understand, and this fibrin is going to form a glue-like substance, and that is how clot will be formed, right? So that is the fibrin cross-linking, where fibrin is acting like a glue and they are forming a strong clot. After the clot, what will be the next step? Fibrinolysis, clot lysis, right? So fibrinolysis, where we are going to see fibrin will be lysed or fibrinogen will be lysed, and this is another important thing which will be measured by thromboelastograph, right? So now I understand, thromboelastography is a dynamic measurement of the hemostatic or coagulation pathway, which measures the thrombus formation components. So what are those components? Platelet aggregation, clot strengthening, fibrin cross-linking, and fibrinolysis, right? So what happens in the thromboelastography? We have a rotatory cup with the whole blood. So now you can see this is the rotatory cup, right? This is the rotatory cup, and in this whole blood is there. which will be later on, they will be forming the clot, right? And this rotatory cup will be rotating at the axis of the 4 to 45 degrees. Remember, this rotational angle of the cup is 4 to 45 degree, right? And in this cup, can you see there is a suspended wire and the pin. So suspended wire and the pin is there. So pin and torsion wire is there. So what happens here, and you can see there is a electromechanical transducer attached to the pin and torsion wire, right? So pin and torsion wire is associated with the electromechanical transducer. So what happens in this thromboelastography measurement or during this process, this cup will be rotating. This cup will be rotating at 4 to 45 degree. So that will be slow, sluggish movement. So this sluggish movement will be simulating like a venous blood. So it will be simulating like a venous blood movement, and in this torsion is hanging. That pin is hanging with the torsion wire. So this pin will be, so what will happen, this will start clot formation, and this clot is going to hold the pin, right? This clot is going to hold the pin. So when this clot is getting strengthened and they are holding the pin, there will be always a mechanical signal which will be going to this one. So from here, there is a mechanical signal will be going from here to here, and then it will be electrified and they will be transmitted to the computer, and there will be a representation of the graph that is called as thromboelastogram, and this entire process is called as thromboelastography. So now I understand that whole blood is in the cup which is rotating, then the torsion wire with the pin is hanging. So once they will start rotating like a sluggish venous blood flow, then there will be clot formation. This clot will hold this torsion, and then signal will be sent through the transducer to the computer, and the graph will be came out, and graph we are going to read as a thromboelastogram, which we are going to discuss later on, right? So now you can see what I have said in the simple manner. Rotatory cup with the blood, where we are going to see pin and torsion is submerged. Cup is oscillating around the torsion pin as I have shown you, and you can see here also cup, there is a cup with the blood and torsion pin is here. As you can see, this is my handmade diagram, and this is the actual picture, right? So now you can see this is going to rotate into this whole blood. This cup is going to rotate around this torsion. So what will happen? Clot will be formed. So that is the same thing. A cup will oscillate around the torsion pin, and this oscillation of the cup will be simulating like a sluggish venous blood flow, right? Clot will be formed, and now they will adhere to the pin. So this clot formation and adherence to the pin will be represented as the elasticity and strength of the clot, right? And that we are going to have a depiction as a graph on computer screen, which is called as thromboelastogram, right? So thromboelastogram, they contain 5 parameters. So remember, TEG, interpretation of TEG with 5 parameters. There are total 5 parameters which we measure in the thromboelastogram or thromboelastography. So how we are going to remember those 5 parameters? See, it's very important to remember the order of the parameters. Then only you can understand that thromboelastogram, that graph. So this we can understand by a mnemonic that is called as RKAML. So RKAML stands for radiation kid with AML, right? So it's a radiation kid with AML. So that is very, very important, right? So if you remember the pathology, what we know that in pediatric age group, radiation exposure is a risk for acute myeloid leukemia. So that is why it's easy to remember, radiation kid AML. So what is this RKAML? R is reaction time, K is K time, A is alpha angle, M is maximum amplitude, LY is the lysis 30 minutes after the maximum amplitude. So reaction time is normally 4 to 8 minutes. K time measures the clot firmness, right? Means how fibrinogen is getting converted into the fibrin and clot is getting stronger. So clot firmness is 1 to 4 minutes. Alpha angle is clot kinetics. See, here we are seeing fibrin to fibrinogen time, how much time it is taking to convert. In alpha angle, we are seeing clot kinetics, means at what angle, means how they are getting accumulated, how fast they are getting accumulated. Kinetics of the fibrin accumulation, 47 to 74 degree. It's angle, right? It's an angle. So MA, maximum amplitude, is clot stability. When platelet will come and they will interact with the fibrin, then clot stability will be measured as a maximum amplitude, which is the 55 to 73 millimeter, right? And after the clot formation, as we all know that fibrinolysis will start, and fibrinolysis will be measured after 30 minutes after the maximum amplitude, which is 0 to 8%. So now you understand Five parameters of the TEG we can remember by mnemonic RKAML. Reaction time, K for K time, A for alpha angle, M for a maximum amplitude, and L for lysis after 30 minutes. Clear? So let's see. Very basic introduction to the TEG graph which I was telling you. So now you can see this is the TEG graph. You can notice this point. At this point we are adding the sample into the cup, that rotatory cup rotating at the 4 to 45 degree. We are adding the blood sample, right? And after adding the blood sample, we are waiting when the fibrin clot will form first time. So initial fibrin clot formation is given as a R time, right? So that is called reaction time when you are going to see the first fibrin clot, right? So this is the R time. After that you are going to see K time. K time is measurement of the certain clot formation, means when fibrinogen is getting converted into the fibrin, right? So that is the timing, K time, right? After that you can see fibrin accumulation, speed of fibrin accumulation we are going to measure by angle. See this here, clot firmness has been started, means the clot strength has been started, right? It is starting, and now you can see from here it was clot formation, then clot strength is getting increased. So that strength, when they are going to increase, when there is a more accumulation of the fibrin, right? So when fibrin accumulation is going on, so that will be called as alpha angle. That is called as alpha angle. That is why I said TEG is the dynamicity of the coagulation pathway. Alpha angle is getting giving information about the fibrin accumulation. And when fibrin will be accumulated, clot will be formed, there will be a full strength. When fibrin and platelet will interact with each other, that is called as maximum amplitude. So now you can see this is the maximum amplitude, which shows the maximum strength of the clot, fibrin plus platelet, right? And after 30 minutes, you can see there is a lysis 30, which will be showing you the fibrinolysis. So now I understand RKAML, R time, K time, angle, MALY. These are the 5 parameters of the thromboelastogram. Now we will discuss one by one, and I will show you the picture again and again, so that it will be easy for you to understand this simple thromboelastogram, right? So R is reaction time. What is the normal value? 4 to 8 minutes. What is R time? So as I said, it is the time taken by the fibrin clot to form initially. So this is the time where you have added the sample, and this is the time when you are going to observe first fibrin clot. First fibrin clot. Now you understand, initial fibrin clot. So this is called R time, right? So R time is the first fibrin clot. So R time is dependent on what? Can you tell me? R time is dependent on what? It is dependent on clot factor. That's what. So if R time is prolonged, suppose R time is not from here to here, it is extending till here. Suppose it is extending till here. So R time is prolonged. So why R time is prolonged? Because of the lack of clot factor. So remember, whenever you find R time is elevated, that means there is a deficiency of the clotting factor, right? So that means there is a deficiency of the clotting factor. And what you will do now? So as a clinician, when you are working in your emergency ward, or in your OBG clinic, or in your delivery ward, so what you are going to do when you are going to see the R time is elevated? So you will have a suspicion for the clot factor deficiency, and you will order FFP, right? So now you understand, this is how question will be asked. In a thromboelastography, R time is prolonged, what treatment you are going to give? So that time you should know R time is prolonged means there is a deficiency of the clot factor, and you will give fresh frozen plasma. So number 1 is done. Coming to the second one, RKAML. K is K time. Is the 1 to 4 minute. This is the time taken by clot to reach the fixed strength of the 20 millimeter. Now you understand why I was telling you persistently that thromboelastography measures the efficiency of the coagulation. Can you measure the strength of the 20 millimeter by PT and APTT? No, you cannot. You simply say that it is the normal or abnormal. You cannot say like that it is 20 millimeter has been reached. That is the beauty of this thromboelastogram, right? Dynamicity of the coagulation pathway we can see, right? So it is the time taken by clot to reach the fixed strength of 20 millimeter. That is called K time. So 20 millimeter of strength has been achieved. That is called K time, which is 1 to 4 minutes. So it will be taking 1 to 4 minutes to reach to that strength, right? Suppose this K time is elevated. What it is indicates to us as a clinician. So if K time is prolonged, see why there is a clot strength is increasing, because fibrinogen is converted into fibrin. Because fibrinogen is converted into fibrin. So whenever this is prolonged, whenever this K time is prolonged, it means there is a fibrinogen is deficient. fibrinogen is deficient. That is why fibrin is not getting formed, right? That is why we are not getting the fixed strength. So now you understand, whenever K time is prolonged, what you should give now? You should give FFP or cryoprecipitate. It is better to give cryoprecipitate, right? So cryoprecipitate will be the good option. If cryoprecipitate is not there, then you can give FFP also if cryoprecipitate is not there, because cryoprecipitate will be rich in fibrinogen. So first option should be the cryoprecipitate, and then second option should be FFP. Done. So RK is done. A. Third is the A. A is alpha angle, which is clot kinetics. Clot kinetics is 47 to 74 degree. So you can see there is an angle. Can you see here? It was R time, then you have seen K time. Now you can see there is a fibrin accumulation is going on. So speed of fibrin accumulation is called as kinetics of the clot development. Speed of fibrin accumulation is alpha angle, right? So this angle is alpha angle, this angle is alpha angle, and this is the speed of fibrin accumulation. So normally it is 47 to 74 degree. And if you find low angle, suppose the angle is here, so low angle, low alpha angle is indicator of the low fibrinogen. Remember, low angle, low fibrinogen, low angle, low fibrinogen. So what will be the treatment? Give cryoprecipitate, right? Give cryoprecipitate, or even you can give FFP if cryoprecipitate is not available. Now you understand, alpha angle is speed of fibrin accumulation. If alpha angle is low, it means there is a deficiency of fibrinogen. Give cryoprecipitate or FFP for this patient. Now coming to the fourth one, maximum amplitude. Now you can see maximum amplitude. See, maximum amplitude is the measurement of the clot stability. Overall, how much clot is stable. So it is the highest vertical amplitude, and it measures ultimate strength of the fibrin clot, right? Or you can say overall stability of the clot. So how you are going to measure the overall stability of the clot? By seeing the platelet and fibrin interaction via GP2B3A receptor. So what is more important in the maximum amplitude? That can be the another question and another concept you should understand as a clinician, because whenever you find maximum amplitude is having some problem, then what you should think of? I understand, as a clinician, what you should think of if there is a problem in maximum amplitude, you should think of there is a platelet disorder. There is a defect in the platelet. Either quantity is defective or quality is defective. So you have to plan for platelet transfusion. So that is why I said maximum amplitude is for measurement of the platelet interaction with the fibrin, and platelet plays 80% of the role, right? And this is 55 to 73 millimeter. Right? K time, you remember K time was 20 millimeter. Now maximum amplitude has been 55 to 73 millimeter. So when you see 55 to 73 millimeter of the strength has been achieved, it means it is fine. And if it is deficiency, if it is low maximum amplitude, suppose this maximum amplitude is not this much, this is this much only, right? This much only, this much, right? So low amplitude, low maximum amplitude, it means there is a qualitative or quantitative defect in the platelet. Now you understand, maximum amplitude is platelet measurement and their interaction with the fibrin. So if it is MA is defective or low, you have to suspect defect in the platelet, and you have to give platelet transfusion or desmopressin, right? Platelet transfusion or desmopressin, which is also called as DDAVP, D-amino D-arginine vasopressin. Clear? So now fourth one is done, RKAML. So last one is the lysis 30. Lysis 30 is lysis at 30 minutes. After the maximum amplitude. After the maximum amplitude, this time will be 30 minutes. Lysis will start. So it measures the fibrinolysis. In a very simple manner, you have to understand, lysis 30 measures, the name itself is telling lysis 30, measures lysin, fibrinolysis after 30 minutes. So whenever you find there is an increased lysis 30, suppose it is increased, right? So that means there is an increased fibrinolysis. Increased LY30 level, increased LY30 level means increased fibrinolysis, and increased fibrinolysis will be seen in hypercoagulation disorder, and in that condition you have to give antifibrinolytics. So antifibrinolytics we have to give, and these are aminocaproic acid or tranexamic acid. So now you understand. So all 5 parameters we have seen: RKAML, R time, reaction time, then K time, then alpha angle, then M was maximum amplitude, and then L is the lysis after 30 minutes of the maximum amplitude. Now this table I have kept just for a quick review, right? Whatever we have learned, I'm just going to tell you in the simple and short manner, and this table will be available in my Telegram group also. After the lecture, I'm going to upload this in Telegram group. So now you can see R time is the reaction time. Number one, RKAML, R time is for, clot factor deficiency, what you are going to give? FFP. K time is for fixed strength of the clot, which shows the fibrinogen to fibrin conversion. So fibrin is deficient or fibrin will be having problem. So in that situation also you have to give FFP or cryoprecipitate. Cryoprecipitate is, preferred. Alpha angle is again for fibrinogen defect, and wherever you find this defect you should give cryoprecipitate. If it is not available, then you go for FFP. Maximum amplitude, as I have told you, this is the maximum clot strength because of the platelet interaction. So always remember, maximum amplitude is with the platelet disorder. So what you have to give? Platelet or desmopressin. And when you are talking about lysin 30, so lysis 30 is for excess fibrinolysis, and you have to give antifibrinolytics like aminocaproic acid or tranexamic acid. So now you understand all these 5 parameters of the thromboelastogram, and whenever you have any defect, what kind of treatment you have to choose, you will be asked in your exam, and you have to perform in your life also when you are dealing with the patient, right? Now, as I have said, why it is very important for a clinician, because it will be a guide for them to treat the patient. If R time is prolonged, give FFP. If K time or alpha angle is prolonged, you give cryoprecipitate first, or if it is not available, give FFP, right? If there is a decreased maximum amplitude, then it means platelet disorder, give platelet or give desmopressin. Or whenever there is a more fibrinolysis, you have to give antifibrinolytics like a tranexamic acid, right? So that is the important for TEG, importance of the TEG to guide a clinician for the treatment plan also. Now you can see these are some of the examples which I wanted to show you. If you are working as a clinician and you are going to read the thromboelastogram, you may find some difficulty. Or in exam time also they can ask you, in INSET exam, examiner can ask these kind of question. So you need not to remember each and every value here. See, you have to catch the point. Catch the point of the disorder, and you look for those things in these graph to come to a conclusion. For example, see, this is the normal one, right? Now if you are looking at this one, you can see this is the normal R time. Can you see R time? What is the R time here? Is it normal or increased? It is increased. So if R time is increased, means it's a platelet, it's a clot factor deficiency, right? So clot factor deficiency is due to either anticoagulant, heparin or warfarin you are using, or there is a hemophilia. So now you understand, if patient is on heparin warfarin, then also he will be having this kind of clot factor deficiency, or he may be a original disorder of the hemophilia or some other clot factor deficiency disorder. So now you understand, if R time is prolonged, it means anticoagulants or factor deficiency you have to give FFP. Now if you are dealing with a thrombocytopenia or platelet disorder, right? Now you look at this one and compare this one. Can you see the maximum amplitude here and maximum amplitude here? See, that's what I said. You don't look everything, right? See, when you are dealing with a patient whose platelet count is less, and you are seeing a thromboelastogram like this, and you are finding that there is a maximum amplitude has been reduced, so that means there is a problem in the qualitative or quantitative defect in the platelet. You have to give platelet transfusion or desmopressin, right? Now you can see this graph. In this graph, can you see lysis 30 has been so prolonged, right? Lysis 30 and been so prolonged, so lysis 30 has been increased. So whenever you find lysis 30 has been increased, you have to suspect hyperfibrinolysis, which you will be seeing in the coagulation, hypercoagulable condition like a DIC, right? So hypercoagulable condition, what you are going to see, can you see the R time here, and can you see the R time here? Hypercoagulability means there is more coagulation, means there is more number of the clot factor or excessive clot factor is present. So that is why R time will be shorter. R time will be shorter. K time will be shorter. So R and K both are shorter, right? Alpha angle, see, because hypercoagulation is going on, so more clot factor, more fibrinogen, more fibrin. So what will happen? Alpha angle will be increased, right? Because coagulation pathway is hyperactivated, so more platelet will be involved. So when more platelets are interacting, so there will be increase in maximum amplitude. So now you understand, this is the importance of the hypercoagulable condition. Now basic thing which you will face in your life as a clinician, and maybe in your exam also, that DIC, because we often come across with disseminated intravascular coagulation. Now DIC has a two stage, in the beginning and later stage. In the beginning they will be having hypercoagulability. So that is why if you see DIC stage 1, everything is like a hypercoagulable condition, because initially all the factors are more, right? Initially, all the factors, clot factors are more interaction of the platelet with the clot factor. That is why R is decreased, K is decreased, alpha angle is increased, MA is increased, lysis is increased. But what will happen with the due process of the DIC? What will happen? The DIC, when it is going on, all the clot factor will be consumed later stage. All the clot factor will be consumed, all the platelet will be consumed. So what will happen? Can you see? R time has been prolonged. R time, K time has been prolonged. Platelet has been consumed. So what will happen to the maximum amplitude? Maximum amplitude is also decreased, right? Because RK is decreased, because fibrinogen is decreased. So alpha angle will be also decreased. So now you understand. So MA, so you can see this is very prominently visible here. All the platelets are consumed. So maximum amplitude has been decreased, right? All the clot factors has been consumed. So R time has been increased. So these 2 points will help you to understand that this is the DIC patient. So I hope I have explained this thromboelastogram in a very simple manner, which will help clinicians as well as those students who are going to appear in this INICT exam on 16th of the June. Definitely, there will be some question from here. This is what my gut feeling says. So must go through this video and share with your friends and share with your clinician friends also, so that they can have a guidance if they want to, if they are following the thromboelastogram, if they are having difficulty in reading the thromboelastography. So thank you so much to all of you, and my best wishes to all students who are going to write their INICT exam. Bye bye.